What I want to do in the next little while is take you out of the acute arena into long-term outcomes and reassure you that despite what you do in the ICU, there are many other issues that can cause bad outcomes along the way in children. Our group has done a lot of outcome research over nearly 30 years now, and today I just really want to focus on the work that we can easily translate back into decisions that might be made acutely, either in the ED or in the ICU. So I want to address three questions. First is, following a traumatic brain injury, do acute cognitive and socio-emotional deficits persist through childhood and into adulthood? Now, I've picked cognitive and socio-emotional difficulties because they're the problems that kids and families complain about many, many years post-injury, and they're the kind of problems that lead to kids with TBI ending up in jails and in trouble with the police and with substance disorders. So that's the focus. The second question, that should be two, not one, can we identify risk factors for these long-term deficits over and above those that we've heard of already this morning? And if we can then we use that knowledge to identify treatments that can help long-term outcome? So starting with the first of those questions, do acute cognitive and socio-emotional deficits persist into adulthood? I just want to talk about three issues. I know concussion isn't necessarily something that you see in intensive care, but at least here in Melbourne, where there's lots of fairly aggressive contact sports, this has become a really big issue. So I just want to touch on that. I want to talk about what the deficits are and how long they persist. So just to start with, some of you may well have even seen the front cover of Time in recent weeks. This is a photo of a boy who had a concussion on the sports field and came off for a little while, then went back on and ended up dying from a second concussion. So it's those kinds of instances that put the, maybe we can say, hysteria in the area of concussion. But there are a lot of kids that cope and recover quite well from concussion. I'm talking to you about both the imaging and the functional outcomes. So just a slide on some work that we've done in a recent study that was published in Cortex, where we compared different approaches to imaging in kids that have concussion and mild injury, just to really see whether there are some techniques that we can use that are more accurate in diagnosing the pathology that might be there in some instances of more mild injury. So this slide just gives you an indication of what we see on it. This is the same child, so CT scan, a conventional MR, and then susceptibility-weighted imaging. And hopefully you can see there that the susceptibility-weighted imaging shows significantly more areas of pathology, small punctate areas of pathology that we have now correlated with outcomes and certainly look as though they are consistent with long-term problems in some of those cognitive and socio-emotional areas. You can obviously do a lot of other techniques, but SWE is something that is just an add-on sequence to a conventional MR, so you can get that information very quickly from your radiologist in the acute setting, whereas things like diffusion tensor imaging and tractography take a lot longer and not really relevant in the acute setting. Just looking at the kinds of problems that we see in the kids in our sample that have got concussion, these are looking at mild, moderate and severe problems at day 5, which is the black line, and day 10 is the blue line. And what we see, as you would expect, is recovery in all areas, with the exception of drowsiness, and the problems really being in the mild to moderate range, not in the severe range. So most kids by 10 days have few symptoms post injury. As I said, drowsiness is a little bit different. If we look then at cognitive skills, and this is based on a computerised cognitive screening task, if we follow these kids with concussion over 30 days, and this is a group that we have pre-injury data on, so they were screened in the community and then we waited for them to have a concussion and brought them back in again. What we find in terms of their reaction times is that from baseline to 5 days post-injury, there's a decrease in their reaction time, so they're slower and less efficient. But there's a big increase at day 10 that in most of our sample correlates with when these kids go back to school. So in terms of clinical guidelines, there's some question around the current guideline of sending kids back to school after a week at home. Perhaps it might be better to keep them away from school a little bit longer. However, there really isn't any literature at the moment to be able to help us make decisions on when is the exact right time for these kids to go back to school. And this second line here is just thinking time. So this is the cognitive load on top of the motor response. And again, we see that 10-day point is the worst function for children post-concussion. So just to summarise what we know about concussion at the moment, and it really isn't very much in terms of evidence. Most kids recover fully, although they might do so a little bit slower than we see in adults. Between 10 and 20% of the kids that we see in our clinic have delayed recovery, that is greater than 10 days. And while there's very little evidence, anecdotally, there are a number of factors that seem to predict this slow recovery. So a recent prior concussion is a significant factor, more severe acute post-concussional symptoms, so that drowsiness, headache and so on, premature return to school and play, and this is one that's particularly interest to me as a psychologist, psychosocial issues such as pre-existing anxiety, family conflict and so on. Those kinds of issues can actually increase the length of time to recovery. So moving to the kinds of deficits that we see after injuries. Now there's a long list, and not all children who have injuries, and now we're talking about more significant injuries, but not all of these problems are present in all kids, but there is a characteristic set of executive problems, poor attention, memory, reduced speed of processing, high-level communication difficulties, and a range of social difficulties. And critically for what I'm going to say later, there are some secondary problems that grow from these, and in particular, family dysfunction. So the burden of moderate to severe TBI on the family is significant and long-lasting. So that's something that I'll come back to. If we look across a range of domains, and this is just a cartoon version of what we see in terms of our data. So if we look in terms of recovery, we see quite different patterns over time. So neurologic recovery seems to be the first to recover in children, and it's pretty much not necessarily recovered, but to the level it will recover to by about 12 months. Cognitive recovery is slower and can last up to 24 months, even longer in some children. The area that's particularly interesting, though, I think, is this area of behavioural and social issues, which I mentioned before was one of the primary problems in terms of these kids having difficulties in adulthood. So these problems tend to get worse over time, and I don't think that we can blame the injury on this increase in difficulties. But what it does do is offer an opportunity for intervention once we're outside that acute time period. And I'll come back to it in detail, but these problems seem to be more related to the child's environment than the child's injury, whereas these problems down here are much more related to child injury. And if we look very long-term post-injury out into adulthood, and this is some retrospective data that we've published quite a few years ago now, that looks at quality of life in young adults who had childhood injuries. And what we find, if we look specifically at the blue line here, is that the kids with severe injury have major difficulties across all areas of quality of life that we measured. So work and leisure, relationships and living skills were all very down compared to mild and moderate injuries. Interestingly though, if we looked at the kind of traditional measures that you would use clinically or that are being used in RCTs now, all of these groups had normal intellectual ability, so their IQs were within the average range, and no psychiatric problems. So quality of life seems to be a measure that's more sensitive to those day-to-day problems. And just again to include some information from neuroimaging, this is a case study of a young boy I saw many years ago now, and so what I've put here is his acute scan. This is his acute CT scan, and he had quite significant frontal pathology, as you can see there. This was an open head wound when he fell off a tractor that he was on with his dad out on the farm. And this is imaging 10 years later, where we can still see, obviously MRI and much better resolution, we can still see that same area of initial pathology here. But what's very interesting is the broader pathology that we see within the whole of the hemisphere here. And this is just a case study, and now a number of researchers have followed this up. We've done some work ourselves. Harvey Levin in Houston has done quite a lot of work, and we find this picture in more severe injuries to be very common. So this atrophy, it looks like atrophy, I think, across the whole of the damaged hemisphere. Not surprisingly, this relates to poorer outcome in terms of cognitive function, social function. And again, from Harvey Levin's group, looking at diffusion tensor imaging, we can see really clearly the difference in what's happening at a brain level in mild versus severe injury. So this is connectivity between posterior and frontal regions. So green obviously is showing the connectivity there. But when you look at the boy who's had more severe brain injury, there isn't any evidence of those connecting fibres. So again, not surprising given those differences in mild and severe injuries that we see differences in function. And then putting all of this together, as you'll be very aware, there's areas of the brain that are more vulnerable to the effects of traumatic brain injury. In particular, the frontal lobes, so dorsolateral orbital and ventromedial regions, all very vulnerable. It's important to keep in mind that as well as them being vulnerable to the mechanisms of traumatic brain injury, they're also the areas of the brain that are developing most rapidly during childhood, which is why we see quite different patterns after child injury to what we see in adults in terms of function. And I've just listed down here some of the areas of function that have been found in normative literature to be associated with these areas. So high-level cognitive skills such as planning, reasoning, attention, capacity to self-regulate and control impulses, and then in the social emotional area, mood, affect, theory of mind, the ability to see another person's view, the ability to feel empathy for someone, and social participation. So all those skills are vulnerable after a traumatic brain injury. So the second point is, can we identify risk factors for these long-term problems? Now, we've talked a lot about injury severity already. I'll just touch on that, but I want to focus on developmental factors and environment. So the notion is in this field of early brain injury, traumatic brain injury, acquired brain injury and so on, that some people believe that there's plasticity of the early brain that will lead to good outcomes. The other opposing view is that the younger the brain, the poorer the outcome. And what we've come to learn from our research and various others is that, in fact, what happens is recovery is along a continuum. We talked about variability earlier on, and that's very much the case when we look further out as well. So clearly things like the severity of the injury, the nature of the injury, is it diffuse, is it focal, the kinds of complications that we've talked about this morning, all of those things are really important factors, particularly acutely and particularly for physical and cognitive function. Developmental factors are important too, so age at injury is really important. We now know that the younger the age of a diffuse injury, the poorer the outcome. And age at assessment, we need to make sure a skill is already developed, is expected to be developed in normal children before we start assessing it and making conclusions in kids with traumatic brain injury. For example, we wouldn't expect a normal 5-year-old to be able to have high-level planning and reasoning skills, so we can't really look at those skills in a 5-year-old with traumatic brain injury and be able to make any conclusions. The third issue is environment, and this is a really critical factor. Most of the research in the area of environment has looked at distal factors like parent education, parent income, and found inconsistent findings, and I'll talk a little bit about that in just a second. The research that is now looking at proximal factors such as the quality of the home environment, the family function and burden, parental mental health, are all factors that are really being seen to be quite predictive in the longer term. And I'm sure it's not just at our hospital, but we find that a lot of the families that we see that come in with a child with traumatic brain injury have a lot of challenges in their life. Often they're single parent, many unemployed, and so more likely to have mental health problems as well. So I just want to quickly go through some data on each of those issues: severity, age and environment. So this is some data out of a longitudinal study that we've been doing. This is just up to 30 months. We're now up to 20 years post-injury. And these are IQ data at very acutely in the first 3 months, then at 12 and 30 months. And these are just the 3 severity groups. So as we would expect, the more severe injury, the lower the IQ score. So this group is right at the lower end of average, around 85, whereas the kids with mild injury are right at a normal level. In terms of behaviour, similar kind of pattern. We're looking at pre-injury behaviour, 6 months and 30 months. The group that has the greatest increase in behavioural problems over time, not surprisingly, is a severe group. So again, severity is a really important factor. If we look at age at injury, this is the same group as I showed you before, but dividing the groups into those that had their injury before age 7 and those that had their injury after age 8. No difference with respect to age at injury for the mild and the moderate injuries. But when we look at the kids that had severe injuries, the group that had their injury younger have much poorer outcome than the group that had their injury older. So this is a time or an age by severity effect where more severe injury at a younger age leads to poorer outcome. And environment, just to give you a bit of a sense of the kinds of things we see with respect to environment. This is some work from Gary Taylor's group in Ohio. He's published quite a lot in this area. And what they did was looked at low socioeconomic families and high socioeconomic families and looked at children's behaviour over time, and they looked out to 6 years. So firstly, if we look at the low socioeconomic group, we find the expected severity difference, so severe injuries, moderate to mild, and this is their control group, so quite high levels of behaviour problems. But then if we look at the high SES group, we find that the frequency of behaviour problems is really significantly reduced, so that the more severely injured kids are really functioning pretty much at normal levels. So SES has a major impact on these kinds of outcomes. And I've just put this little picture up here really to emphasise that it's not just at the level of function, but it's also at the level of brain. So in low SES families, or low SES rats in this case, what we find is behaviour is impaired, but also the structural connectivity within the central nervous system is reduced. So brain development is impacted by low SES. So again, a severity plus an environment double hazard. And if we look closely at the proximal area, which I mentioned to you before, and compare kids who have got abnormal versus normal outcomes, and this is again in terms of behaviour, we can look at what predicts those. So severity, yes, so a GCS score has a significant effect on these outcomes, but family burden, family function, parent stress and maternal depression, all extremely significant. And that brings me to my last point, which I'll not spend too long on because I know it's lunchtime now. What we have done is looked at this potentially modifiable risk factor of environment, and in particular mental health, stress levels of family. And we've now conducted a number of different trials looking at parent intervention to support their children. I don't want to go into the details. For those of you who are interested, this is a cognitive behaviour therapy program that parents sign up to, where we help them analyse their child's difficult behaviours and then respond to those effectively. And some data from this that's just been published by Damith Woods, who's a PhD student who worked on this project, shows the impact of this intervention. Now, this isn't an RCT. The RCTs have been done in other groups with this particular intervention, so it's been found to be an effective treatment in a number of groups. But what we found with our TBI group was his norm across here. And if we look at kids' behaviour, both internalising and externalising, there's a big reduction in those on parent report over time. And there's also a reduction in their inhibition and their emotional control. So significant decreases there. I won't go into it, but the parents also reported decreases in their levels of depression and stress and anxiety, and improvements in their family function. So we're now continuing on that approach, and this particular intervention is used fairly commonly now in our rehab settings to hopefully good effect. So just to conclude, the data that I've shown you, and some that I haven't necessarily talked about, I think it shows that not surprisingly, kids have an elevated risk of cognitive and socio-emotional problems that persist over time into adulthood after they've had a TBI. Often the full consequences aren't known, and new problems may emerge over time, and so acute follow-up needs to be supplemented by longer-term follow-up as well, where it's possible. Long-term outcomes are determined by multiple factors, so yes, severity is an important factor, but age, developmental stage is important, and environmental factors are also critical. I've shown you that interactions occur across these areas. And I think I also mentioned early that injury factors are better predictors of cognition and physical outcomes, and environmental factors are much better predictors of socio-emotional outcomes. So it really does seem that there's two streams of outcome. And just finally, I think that this kind of data helps us to identify acutely who we should be targeting in terms of longer term outcomes, so more severe injury, younger aged injury, social disadvantage. It also highlights the importance of longer term follow-up, and particularly at developmental transitions, so school entry, high school entry, moving into the workforce and so on, where systems around the child need to change. And lastly, targeting the child's environment is a really critical opportunity, I think, to improve outcomes. Thank you.